to introduce Dr. Hilary Babcock, who many of you may know from her fame on CNBC and NPR. So now she's a national presence. But by way of quick background, Hilary is very proud of her origins in Texas, went to Brown University for college, went to UT Southwestern, and we have a lot of UT Southwestern, right? Oh, sorry, that's Austin. Sorry. You know, all of Texas is like its own world. So, and then came here for residency. She was a chief resident, and her husband is a distinguished clinician and educator, Dr. Andy White at St. Louis Children's Hospital. They have 3 kids. Hilary did infectious disease here and is an extraordinary hospital epidemiologist and an infectious disease expert on occupational health and safety, influenza, pandemic preparedness and response, and has had funding from NIH and CDC for her work looking at bioaerosols and transmission of infections in the workplace. So as you might imagine, we are thrilled to have you here today, Dr. Babcock, giving us an update. And we just want to clarify, we'll take questions at the end, and any questions that we can't answer will, from the Zoom audience as well, we'll do on the frequently asked questions on the Zoom site as well. So please join me in welcoming Dr. Babcock.
Good morning. Thank you all for being here at what will probably end up being one of our last large gatherings of people all in the same place. My husband said I should just announce there's too many of you here, it's canceled. But I won't do that. I will just say in my own defense that I found out that I was giving this talk today on Tuesday. But luckily, I have been talking about nothing but coronavirus for about the last 2 months, so I think I can do a fair amount of this without much trouble. So just to point out, I have no disclosures to share. I'm going to go through some biology, epidemiology, clinical features, talk a little about testing, infection prevention, treatment and research. I want to give a big shout out to our second-year ID fellows. Some of them are sitting right over here. Josh Hendricks, Adriana, Franny. They have been helping us sort of gather together materials and reviewing things that are posted. As you might imagine, there's a lot to keep up with. So they made these slides, and I have edited them a little bit. Any mistakes are definitely my own, but thank you for helping me be ready for this talk today. So a little bit first about biology. The coronaviruses, as you know, there are a lot of common coronaviruses. We've been able to see those on our respiratory viral panel for some time. I'm sure that by now you all know this, but the respiratory viral panel does not pick up the coronavirus, SARS coronavirus 2, the COVID-19 causing virus, but it is in the same family of viruses. And you can see that coronavirus is down here, about 25% of common colds. Am I in trouble? Okay. What did I do? Okay. Okay, good. About 25% of common colds are probably associated with coronaviruses. They rarely cause viral pneumonia and rarely predispose to bacterial pneumonias. You can see a little of the genetic epidemiology down here. These are sort of common cold viruses, common cold coronaviruses. And then here is the MERS tree, and then here is SARS-CoV and SARS-CoV-2, the virus that causes COVID. The virus, all of these coronaviruses bind to the ACE2 site in respiratory epithelium, and the SARS-CoV-2 can infect both upper and lower respiratory tracts, which probably explains some of the clinical syndromes that we see with this virus. That's all the biology you get today. So EPI, just to compare the COVID-19 outbreak so far with the prior coronavirus outbreaks, you can see SARS and MERS shown here. You can see that the global spread of COVID-19 is already much broader than what we saw with either SARS or MERS. The mortality rate looks to be substantially lower than those 2 infections, though I think we can all agree that a lot of this data is still in flux. The mortality rate that's quoted is in the 2 to 3% range. My personal feeling is that's probably going to be lower when we have a better sense of the full denominator. I think there are a lot of people who have low level, less severe infection that probably weren't tested, probably weren't identified. And when we add all of those into the denominator, the percentage of people that are infected that are dying, I think will probably be smaller. Still substantially higher than influenza, but lower than maybe what we're quoting right now. This is a global map with confirmed cases. So you can just see that this has really spread across the globe fairly quickly. So this was emerging in the end of December. It's now March and was just declared a global pandemic. And these graphs that we pull and put into a slide are already outdated by the time I get here to tell you about them. So last night, the total was 1,311 US cases with 38 deaths according to the Johns Hopkins Global dashboard map, which I highly recommend to all of you if you have not seen it before. In the US, we've also had a March change over the last few weeks, and you can see the distribution of cases shown here. We still really have localized community spread. So in the Seattle area, Northern California, Westchester County and New York, around Boston, connected to this Biogen business meeting that resulted in a remarkable number of infections. And then a few cases, as you can see, spread across other areas in the country. As you know, I think there have been 2 confirmed cases in Missouri, 1 in the St. Louis area, 1 in the Kansas City area, and we continue to be on heightened alert to identify more. This virus, as you know, first detected in China, first infections linked to a live animal market. We don't know for sure where this arose. There are definitely coronaviruses that live and colonize bats and bat populations. And it looks like the original SARS infection also probably started from bats, potentially moved into a civet, a kind of wild cat. MERS also probably started in bats. Most humans have gotten it through contact with camels. And we don't really know what the possible secondary mammalian host was for this coronavirus yet. There's some possibility that it is the poor trafficked pangolin, but hopefully we'll find out more about that as that gets more information. This was just declared a pandemic by WHO yesterday. Transmission routes for coronavirus. Most of the coronaviruses spread through large respiratory droplets. So these are droplets that are expelled when people are coughing and sneezing, as you know. We think that asymptomatic transmission is possible, but probably the contribution of asymptomatic transmission to overall transmission dynamics is pretty small. These viruses mostly seem to go through these large droplets. Mostly that happens when people are coughing and sneezing. So as you might imagine, you're not coughing and sneezing, you're spreading less of those into the environment around you. Close personal contact can also lead to spread. And then the virus does survive on surfaces. There's not great data yet to quantify exactly how long, but it can survive on surfaces for at least hours, potentially longer. And so touching contaminated surfaces and then touching your eyes, nose, or mouth can also cause infection. There's a lot of work going on to try to determine where else this virus may be living in people and identify if those other sites also carry risk of transmission. So we have some limited data. We know that the virus can be found in upper and lower respiratory tract specimens and BAL fluid. It has been found in blood and in stool specimens, but we don't really know specifically around the question of fecal oral spread, how live and viable that virus that's been found is. Most of these studies have been done using PCR. So I think in general, we can rely on the primary mode of spread being this droplet transmission. It looks like the viral shedding is highest in the first few days of symptoms. So this is a little bit closer to influenza is more like this. And the other prior SARS virus had shedding that peaked a little bit later in illness. And shedding has been determined to continue for probably 7 to 12 days, maybe for longer, maybe over 2 weeks. And we know that patients that recover can actually be PCR positive after symptoms resolve for several weeks, but that we don't really know whether that's live virus or whether those are just remnants of virus that was there in the past. There's been a lot of work to try and determine what the R0, suddenly everyone in the country knows about the R0 and is talking about epidemiology, which is very exciting for me. So I think that this is a really good visual to try and see how many cases one case is likely to infect. So you can see that it was pretty small for MERS, lower for influenza than for COVID-19, all shown up here. So a single case in the middle infects less than one person, 1.5 people. I was telling my son about this and he's like, how can you infect less than one person? But it's an average, so we talked about that. And then you can see these other diseases that are more easily spread. And I just want to heighten awareness always of measles, that we use as the sort of benchmark as one of the most infectious diseases and viruses that we know. And the average one person can infect 18 people with measles. So certainly this is an infectious virus. We're certainly worried about it. People who have gone on the news that say this is the most infectious virus ever are wrong and have never heard of measles. So there is also a lot of trying to sort of look at the combination of transmission and fatality rate to get a sense of what this epidemic might end up looking like. This is kind of a nice graph that shows the average number of people infected by each sick person. So again, measles over here in the 15 to 18 range. And then the mortality rate. So up here you can see MERS, smallpox, Ebola have very high mortality rates. This is a logarithmic scale over here, so things are closer than they appear. But these, this box is probably somewhere in there is where this virus will end up in terms of both transmissibility and fatality. One thing you may be hearing a lot about as well, of course, is community mitigation strategies. This is why the Final Four will not have any audience at it, I guess. I'm not really a basketball person, much to my husband's chagrin, but so a lot of these measures, a lot of conferences have been canceled. Large gatherings will be increasingly canceled as well. And really the goal of this is that when we talk about that R0 of one person can infect 2 or 3 people, that is data that's generated early in the epidemic for this epidemic. So that's before community mitigation strategies and other strategies were put in place. And our goal in public health is to decrease that R0 down to less than 1, so that one person can get through their whole illness without infecting another person, and then we can really bring this under control. So all of these community mitigation strategies are designed to sort of squish the epidemic curve. So what we want is for this curve not to be super tall and narrow and overwhelm our hospitals, our emergency rooms, our healthcare systems, as we have seen and heard from other countries that have gone before us with this epidemic. What we want is to squish that curve down and have sort of a slow burn of constant low-level transmission until we can get it more under control in a way that allows our healthcare system to keep up, so that we have sufficient beds, so that we have sufficient ventilators, so that we have sufficient healthcare providers to manage all the patients that are coming our way. There's been a lot about how to prevent community spread. So these are, as I say on all of these interviews, these are not sexy interventions. These are the same interventions we highlight for flu, but I really think as healthcare providers, it's also important for us to speak to these common sense interventions that really do limit transmission in the community. And the community also means like between you and your colleagues here in the halls of the organization. So limiting touching, don't shake hands, wave. I'm not actually a big fan of the elbow bump. I think we all cough on our elbows and then we touch elbows with each other. Not a big fan of that either. So I'm highly in favor of waving these days, potentially a small bow, but there are lots of options to consider. But all of those are really much better than constantly sharing germs with other people by hugging and shaking hands and touching. And then hand hygiene just really all the time. So I know in a hospital, we are all supposed to be doing hand hygiene all the time, and we are not always doing it all the time as much as we should. This is a good reminder that hand hygiene is really a cornerstone for preventing transmission for all of these infections. And hopefully with coronavirus, people will have sort of a renewed vigilance and excitement about hand hygiene. Travel restrictions is another way to try and minimize influx of potentially infected people from areas that have higher rates of infection. There is a little bit of a balance there, of course. Once you have people already in your community that are infected, then the impact of those travel restrictions may be more limited. I will refrain from any further comment about that. So I do want to pause. This was not in the slide set, so I threw this slide in just to be able to remind me to spend a few minutes talking about what BJC and WashU have been doing to prepare for this coronavirus pandemic. So BJC set up a virtual incident command center at the end of January, started communicating frequently with all 15 of our hospitals across the area, bringing them information, helping them to put together travel screening, signage for patients and visitors at all of our intake sites so that we could identify patients that were potentially infected, with the real goal of sort of this three-part process that we would identify potentially infected patients, isolate them, and then call for help. So that was sort of the initial structure. As we start to have more and more patients, that informed piece will rely more heavily on providers knowing what the first steps to do are, rather than putting someone in a room and then calling infectious disease or calling infection prevention. We will be trying to get more information out so that more things can be handled remotely and discreetly. We've been working a lot about personal protective equipment, and we'll talk a little bit more about some changes in the recommendations that have just come out from CDC to align more with WHO and some other areas. So we'll talk about that in a little more detail. We have our supply chain people that have been working really diligently again since the end of January to say we're going to need a lot more gowns, gloves, isolation masks, N95 respirators, face shields, and to really do our best to get those supplies in and warehoused and cached and available for all of us. This is still a big challenge. So nationally, as you might imagine, everyone has been trying to do the same thing. A lot of these supplies are actually manufactured in China, a lot of them in the most affected areas in the Hubei province. So there are clear shortages of all of this material. And so a lot of our guidance really has to balance what we recommend that you do and what we need to do to be sure that in 2 weeks, 4 weeks, 6 weeks, we still have the protective equipment that we need to safely provide care. We've worked a lot with clinical partners to try and develop some clinical pathways, again, from different places, starting in clinics, starting in the emergency room, what to do when somebody is admitted to an ICU and needs aggressive clinical, critical and supportive care. And we've pulled together teams of critical care physicians, anesthesiologists, pulmonary doctors to really think about what that would look like and develop some sort of common pathways that will be helpful here and at other institutions across our organization. We've done a lot about travel restrictions as well, as you may have heard or experienced yourself. But we are really trying to be sure that someone who is potentially exposed to coronavirus while they were in another location does not come back into our organization and provide care for a patient when they may be potentially infected. So everyone who has traveled internationally has been instructed across BJC and WashU to check in with occupational health before they come back to work. Occupational health reviews where exactly you were, what you were doing, what kind of contacts you had, and makes recommendations that may include 2 weeks of furlough, not being able to come to work at all, may include 2 weeks of symptom monitoring daily and allowance to work as long as you don't have symptoms and you wear a mask. Or maybe like it's fine, you know, you went to Iceland and you can just come back to work and there's nothing to worry about. So that screening is really important, and we have that in place again across the system. And we are constantly monitoring and adding to those lists of places. So if you have recently been in Westchester County now, we're a little worried about that as well. If you've been in Seattle, Northern California, these are other areas with expanding outbreaks that we also have to consider what the potential risks are. One of the questions we get is, what is the role of that mask for a healthcare worker when we bring them back to work and let them work in a mask? There's been, as you also have probably heard, a lot of discussion on the news about whether people should be wearing masks in general in the community. And in general, in the community setting, wearing a mask on an asymptomatic person to prevent infection for themselves, not thought to be particularly useful. Most people in the community aren't using them correctly. Their exposure risk at any given moment is pretty small. But for someone who is potentially infected or is infected, that mask actually provides significant source control and limits the amount of spread of these respiratory droplets that are infected into the environment or to the people that they are immediately with. So our goal with those for healthcare workers that we request to mask is the same as what we do for people who cannot get an influenza vaccine for some reason, that they wear that mask so that if they were to become ill, we would know that that source control was already in place before they started to have significant symptoms. So that's the rationale behind that process. That was a big sidebar, not in the slides. And again, we'll take questions at the end, and if you have questions about any of these things, we can talk about them. So clinical presentations, most of you have heard this already, but in general, fever, cough, and shortness of breath. Interestingly, it does appear to have some symptoms that, like myalgias and arthralgias in some patients, headaches in some patients, GI symptoms in some patients, but less common. And this trio of symptoms is really the most common. It's not 100%, so I think 80–85% of the patients that we've got data on had fever, but that means that some percentage of them obviously did not. The clinical spectrum really ranges. So from the data coming out from China and other affected areas, it looks like about 80% of people will have mild disease. So non-specific signs and symptoms, sort of a respiratory viral illness that you might think was a common cold or might be something else. About a smaller percentage will progress to more severe disease. There have been described severe pneumonias with respiratory failure and septic shock. Those are much more common outcomes in people that have underlying medical conditions that put them at risk. And then asymptomatic infection, as I said, probably occurs at a pretty high level in children, may occur in adults at a reasonable level as well. And we just don't really have any way of knowing that until we get to the stage where we can do sort of large serologic surveys of whole populations. One of the sort of bright spots, if there is one, about this infection is that it does not appear to cause particularly severe disease in children. So most kids that have been reported to be infected have had mild disease. I suspect as a mother of children that they are still excellent vectors of disease spread. And they may be passing disease around between others, but luckily do not appear to have severe illness often themselves. There is a progression of symptoms during this infection as well. So the most common presentation is sort of a slower onset with a week of sort of myalgias, malaise, cough, low-grade fever that progresses more in the second week to more shortness of breath and worsening cough. And that's where the people with mild disease sort of either continue with mild symptoms and get better or start progressing down more of a viral pneumonia path and get more ill. In general, some average times just to have in mind, the median incubation period is probably around 5 days with a range of 2 to 12. So most of the work exclusions, most of the quarantines that have been put in place have been 14-day quarantines to cover that whole range of incubation period from exposure to symptoms. Most of the mild cases, again, in that second week are getting better. And the more severe cases in that second week are getting worse, and they may have symptoms out a lot farther to 3 to 6 weeks. Some of the key findings that have been reported in the literature, people often have some bilateral patchy sort of shadowing on their chest x-ray, but they may have a fairly clear chest x-ray, but if you get a CT scan, then they have this bilateral ground glass opacities that really is not very specific. So it looks mostly like a viral pneumonia. It can't tell you which virus it is. It just looks like a viral pneumonia. Lymphopenia has been reported in lab findings on these patients, and the inflammatory markers are kind of inconsistent, so not really a good marker for us in defining who might be infected. As you've all heard, people with comorbidities and people at older ages are at increased risk for severe illness and death. There's really not a lot of data yet about immunocompromised patients. I think we all assume that they would count as being at increased risk for poor outcomes. There's just not a lot of data about them yet. But you can see here what the death rates are by the type of underlying condition. And you can see that these mortality rates are significantly higher than what we're sort of quoting as an average across the whole population. And then you can also see here, again, there have not been, this was again from February 11th, so unless this has been updated, which is possible, there were no fatalities in children under the age of 9, and a very small number in patients 10 to 19, and then people really up through 40s, 50s, pretty low, does jump a little bit in 50s, and then, but you can see it really jumps up 60s, 70s, 80s, that mortality rate really goes up. So definitely age related. And as somebody now in my 50s, it's really distressing to start seeing that older adult number come lower and lower, closer and closer to my age. A couple of comparisons. I think we've mentioned a few of these things already. Just as a reminder, right now in the St. Louis area, we have a lot more influenza than we have coronavirus. So not that you shouldn't be thinking about coronavirus, but you should really be thinking first about influenza. It's much more likely that any given patient without a specific exposure who's in front of you with fever and a cough, much more likely right now still to have influenza. There are some differences in clinical onset. So influenza is one where often people can tell you, like, I started feeling bad at 2 o'clock in the afternoon yesterday. That's not really what we've been seeing reported from COVID, where it looks like a more gradual onset of symptoms. The symptomatology is fairly similar, except that we rarely see rhinorrhea and congestion reported from these COVID-19 cases. Risk for severe infection looks similar, except again, children do not appear to be as severely affected. And in the reports that we've seen so far, there has not been reports of increased bad outcomes among pregnant women. It may be that we just don't have enough data for that yet, but we have not seen that signal, which is a little reassuring. The incubation period for flu is really short. It may be as 1 to 2 days after exposure that you start to have symptoms, though it can be out to 5 days, but 5 days is like the outer limit. Usually that's quoted. And that, of course, is different from coronavirus as well, where that incubation period averages around 5 days with a range out to 14. And there can be pre-symptomatic transmission of flu that's been well documented, and just a little more up in the air still about COVID-19. And then we talked a little bit already about the R naught. Okay, let's talk about testing. Testing has been kind of a mess, as you all know, across the entire country. So definitely slow on the uptake from a US overall global perspective in terms of getting testing ready, out, and available. And this is still a big limitation. So, you know, just up until probably a week ago, tests were only just coming online in our state health departments, and the CDC was still doing the bulk of the testing. As you probably all heard, there was a little back and forth where the CDC said we have a test and they sent it out, and then it didn't perform as expected in a lot of the state labs, and they had to sort of revise and redo to get that to work. This is not a totally simple, this is not sort of a plug and play test at the moment. Like, there are significant sort of technical processes that are required to do the testing with the kits that are available. And there just remain challenges in making that feasible for high throughput. In general, testing criteria remain pretty similar in our area. These patients, again, are less likely in this area to have COVID if they have not had some epi risk factor or some travel connection. So we look at the local epidemiology. Have they traveled? Because we don't have a lot going on right here locally, the clinical course of illness that we've discussed, and then have they had contact with a lab confirmed case or a history of travel from the unaffected area within 14 days. And because still in our area, these other viruses are more common, testing for those viruses is prudent before leaping to coronavirus as a likely cause. The tests that are available are all these PCR assays. And just as a reminder, like, I know we say this every year for flu, but sample collection technique is really critical. These are NP swabs. So they really have to be sort of pushed all the way back. We talk about, like, calling it a brain biopsy. If your patient is not coughing and sneezing and crying when you're done, you probably didn't do it right. This is not an anterior nares swab. This is really a nasopharyngeal swab. Sorry. How to test at BJH is also sort of evolving. As you all know, the state health department has been the only place that we could get testing until fairly recently. And all of that testing had to be approved by the state epidemiologist. So there wasn't a way for anyone to say, like, despite what you might have heard on the news, for anyone to say, like, oh, I want a test, I'm just gonna go get a test. So this is only recently opening up a little bit with some commercial labs and some other university labs willing to accept sent in samples. So that is still in evolution. As of now, most of the testing is still going through the health department, but our lab here is looking at the ability to send samples to the University of Washington lab, which would still have a test approval process, but would not have to go through the state epidemiologist, which tends to take a little bit longer and has a lot of forms and other things associated with it. As we mentioned, NP swabs for testing also recommended is an oropharyngeal swab. So both types of swabs are recommended. They can be done on lower respiratory samples. In general, aerosol generating procedures are not recommended for these patients because of risk of transmission to people around them. But if they are getting a bronchoscopy, because that's clinically required for their management, or if they are already intubated and they are doing a tracheal aspirate, then those lower respiratory samples can be sent for testing as well. There is, just to note, in line with all the other shortages, there are impending shortages of the test reagents that are used to run this test. So even as we move to more easy availability of these tests, there still is incumbent on all of us to be thoughtful and to think about what the risk really is, to rule out other causes before we start widely testing everyone, given that we have a potential for running out again of test availability, which is not what anybody wants. So work in progress, and we'll keep you posted. Infection prevention. So there have been updated guidance, as I mentioned, from the CDC that just came out, I don't know what day it is, a couple of days ago, and has been updated to align the infection prevention recommendations with the WHO and with several states that have already put out their own infection prevention guidance, and with Canada. So the initial guidance that the CDC put out, like they do every time we have a new infection of any kind, was for pretty much everything you can think of, that's what you should use, because we're not really sure what's gonna happen. They do this every time, and then they have a lot of trouble walking that back, and it makes me irritated every time, and this time too. What we know about coronaviruses is that they are largely spread, as we talked about, through these large respiratory droplets. So in the initial days, maybe when we had this new coronavirus and we weren't sure if it had evolved or changed in some way that meant that it was going to be more like TB or more like measles, it maybe made sense for a brief moment to think about using respirators for the care, for all of the care of all of these patients. But we really didn't see that kind of spread and that sort of R0 from these patients. And so really the same protections that we use for most of our respiratory viruses, surgical or isolation masks, eye protection is recommended, and then gowns and gloves, because it can survive on surfaces, are what's makes sense rationally. And the CDC has now aligned their guidance to essentially say that that level of protection is fine, is totally adequate and sufficient. And that N95s and respirators and negative pressure ventilation should really be reserved for patients that are undergoing aerosol generating procedures or likely to undergo aerosol generating procedures. And those include intubation, extubation, bronchoscopy, nebulized medication administration, BiPAP, CPAP probably. Those are all things that we think can generate smaller particles due to the airway manipulation that happens during the test. So this is a big step forward. This is going to actually make a lot of things easier in managing these patients and being sure that they're getting the care they need and not overwhelming other systems within the hospital. This also means that sample collection can really be done anywhere. So sample collection can be done anywhere that people have a respiratory mask and potentially eye protection and gloves. So samples can be collected in people's offices. Samples can be collected in our clinics. Just the way we do for flu, without having to go through a whole process of being sure that they're in negative pressure and everyone's wearing N95s, which has really clogged up our emergency room with spending 6 hours essentially to try and get an NP swab on a patient, which is not a good use of resources really for any of us. They have also made clear that negative pressure ventilation rooms may be preferred, but they have added this clarity around this is if they are available and if it is feasible. So we have a fair number of negative pressure ventilation rooms in this hospital. We don't anticipate using all of them for these patients, but rather probably cohorting patients in specific areas of the hospital where dedicated care teams can focus on those patients, and not use, say, a negative pressure room in an oncology unit for a single COVID patient, but instead keep that COVID patient somewhere else that doesn't include increased risk for those patients in that area. So a lot of work is going on here with the BJH team and with Dr. Warren to try and get those plans all hammered out. They are largely outlined and will be put into use as needed. As I mentioned, we have shortages. So we have also put in place N95 conservation strategies. So these shortages are national, and you should have gotten some information about this process, and hopefully you have noticed that N95s, and hopefully this is true, are not sitting in boxes next to patient rooms. There are sort of two reasons for this. One, we really want you to take one N95 respirator. We want you to use it and then put it in a bag and carry it around with you and use it again. And that's because we don't have enough for everyone just to use them and throw them in the trash. So we should limit the number of people going into any room that requires N95s so that we can preserve the supply that we have, and we can safely reuse them multiple times, essentially until they are wet, soiled, falling apart. So those are important so that when we need them, we will have them. I was going to say something else about N95s, and now I forgot what it was. Okay. Oh, the other reason that we are having to control them and have people actually go ask for them is that, as you might have noticed, there's a little concern in the community about coronavirus. And so the boxes that we have had out of N95s and of surgical masks are just walking out of the hospital. And so probably patients, visitors, probably staff, and ourselves are taking these boxes and taking them home to their families because they are worried. So we have been able to track in supply use across the system that our usage of N95s and surgical masks has really increased greatly over the last few weeks, even though we have not had any actual COVID patients and our flu rates have been pretty stable. So that's another reason that we really need to control access to them so that they are available for healthcare workers who need them the most when they need them the most. Just a quick note on cleaning. Standard cleaning products that we use in the hospital all the time already are effective against COVID-19. So there is no requirement for special products or additional cleaning. It is the same products and process that we use already. A quick word about treatment and research. I'm not going to go into a lot of detail about this. There are no approved drugs for COVID-19, not surprisingly, since it just emerged a couple of months ago. There are some experimental and anecdotal reports of Kaletra being used. That's an older HIV medication, a combination of lopinavir and ritonavir. Some reports about interferon. Potentially, there is interest in looking into therapeutic monoclonal antibodies as well. Remdesivir is a drug that has been used with some success anecdotally. So it is an investigational agent. It is not on the market already. The novel nucleotide analog that has activity against coronaviruses in animal studies and in vitro. And there are some randomized trials underway to try and evaluate its use. And it has been used in a compassionate use arrangement in some institutions. The first COVID-19 case that was in the state of Washington was treated with remdesivir, and he did recover. Whether he would have recovered without remdesivir, of course, we have no way of knowing. But that is one drug that is out there that could be requested or used in the context of a trial if that was available. So I'm going to stop there. I know that I am not using my whole time. I want to have plenty of time for questions with all of you. I want to just be sure to thank all of the people that are making all of our coronavirus work possible. Our ID fellows I mentioned, the rest of the hospital EPI-ID faculty, Dave Warren, Steve Lawrence, and Steve Liang have been working just sort of flat out to be sure that our hospital and the university and coordinating and consulting with the Danforth campus as well so that we are all on the same page. Our other faculty that also work in hospital EPI have been helping out as well. And then of course, the rest of the ID faculty have been sort of picking up the slack while those of us who are doing this are doing this. We've worked very closely with BJC, BJH, WashU leadership, and have been very supportive. And then we have loads of clinical partners and our lab partners that have been a huge help for us as well. So I'll end on this super positive note from Dr. Fauci. But I think this is really true. We are going to see a lot more cases, and things are going to get a lot worse before they get better. And the stories that are coming out from Washington State, from Italy, from other countries that have gone before us down this road are really very sobering. And some hospitals that we have heard from, colleagues and friends, it was really sort of a 3 or 4 day process from having a few patients in their hospital and a pretty manageable process to completely overwhelmed, patients in the hallways, canceling all elective surgeries, clearing the hospital for COVID patients. It can be a very fast ramp up. And so I think that a lot of the work that's been going on is to be ready and prepared. We hope that it will not take off at that same speed here. We are lucky in the middle of the country to be a little protected and to have a lot of time to prepare and get ready. But I think we're going to see a lot of cases. We're going to see a lot of cases across the country. We're going to see a lot of cases here. And we really need to be prepared and planning for how we're going to manage that big surge. So I will stop there, and I am happy to take questions.
Hilary, that was simply an outstanding talk on amazingly short notice, but I know you do this, you know, historically, put stuff together really fast, so I'm impressed. We have time for a few questions.
Yes, so do I need to repeat the question? So the question was about potential drug shortages, as many of our medications are also manufactured in China and in other affected countries, and what we can do or are doing in order to try to mitigate that risk. So we have also been working with system pharmacy teams on a couple of different sort of parallel paths. One, they have been looking at sort of our most highly used medications across the healthcare system and looking into in more detail where they are sourced from. And are there any anticipated difficulties with where they are sourced from? And can we get in a little extra now to have as a cushion? We have also gotten together with our ICU colleagues and really talked about what the clinical care of a critically ill patient with COVID might require. So there are things that we don't really think about necessarily as a supply that could run short, but saline and IV tubing, pressors, sedation, all of those things. So we are also looking at what our current usage is and getting in, again, additional supplies of all of those things so that we have a cushion on those as well. So the question was, given what we've seen in other countries, when do we expect the peak nationally or locally, and when would we expect that to sort of go down? I think the when we expect it to go down is actually harder to know how that's actually going to play out. I think a lot of the work that people are doing and the work that other countries are doing on social distancing really have a lot of impact in what the peak is. There are some, I don't say this lightly, but there's actually some really good information on Twitter. So there are a lot of people who are doing a lot of modeling and have a lot of interesting graphs about what the expected outcome is. Some have looked at sort of cases over time in other countries and then lined up the cases over time in the US. And they estimate that we are about 2 weeks behind Italy. So if you look at that, I think we're going to see a big uptick in the next, I mean, we already are, and it's pretty localized, but we're going to see more. And modeling has shown that that's going to rise really fast. What we can also see is, for example, Singapore and Hong Kong really blunted their curve by mostly with a lot of aggressive testing and aggressive isolation practices, but they really blunted their curve. So it's not following the same epidemic curve that has been seen in most of the other countries. South Korea had the same epidemic curve as most of these other countries, but then have plateaued, again, with aggressive testing and control measures. So there's a lot that's just still up in the air, but I think, you know, it's going to explode pretty soon.
Bill?
Right. I do think here in St. Louis, I'll just add one, it's nice to see us in the news in a positive light, but a lot of people have been pointing out that in the 1918 influenza pandemic, if you compared the responses, say from Philadelphia is often cited, compared to St. Louis. St. Louis took what were thought at the time to be sort of too early and very draconian, shutting down, closing movie theaters, shutting down a lot of community events and community places where people would get together, and the curve in St. Louis was substantially different than the curve in Philadelphia. So I do think, again, we have a little extra time, and it's good to see so many things being canceled and so many people, you know, getting this message. But I think that, as Bill said, that's what drives the curve.
Tanya?
Yeah, I totally agree with all of the frustrations that you are expressing. I think most of us do. I think what we could say, hopefully, testing is starting to expand. There are commercial labs that are coming online. There are more academic centers that are coming online. As long as the supply of reagents and these other things can keep up, which I think is not, you know, for sure a given at the moment, that we should have a much better handle on how things are going. But in terms of when we know that we should be doing these types of things, you know, now we should be doing them now. Right. No, and I think that we're going to have to see like what the clinical picture is. You know, I think our hospitals and healthcare system are going to be inundated with patients. We're not at some level, we're not going to need testing. We're still going to want testing. And don't get me wrong, but right. And still, as I said, in the St. Louis area, if they have no epi contact or travel, they are more likely, I'm sure you have lots of patients every year with negative viral swabs and symptoms, swab collection technique and testing shortages and et cetera. So I'm not saying that there aren't unidentified patients, just that we can't necessarily assume that every patient that has a negative test with no risk outside of St. Louis has coronavirus. I give those patients the same recommendations I give every respiratory viral illness patient every single year that we don't come up with a diagnosis on, which is you should stay home until you are afebrile for at least 24 or 48 hours, and you should isolate yourself from others so as not to infect others, and you should follow those same practices. So, I mean, that's what we have and that's what we do, and I think that's what we should still be doing at this point. And I share your frustration, don't get me wrong. I want there to be more available testing, but we are where we are.
So people really are working very hard to accelerate test capacity here. So the lab, the micro and molecular biology lab in BJHID, there are lots going on right now to really increase capacity for testing. So, nobody is holding back and hoarding or preventing testing right now, except for the fact that there is not capacity. Tiffany?
Okay. I'm trying. Sorry. Yes. This question was, I did not repeat Tanya's question, but we had a whole conversation, so that would have been harder to transcribe. This question, there were two questions. One was about expectations on supply availability, both on N95s and testing capacity. And then also, no, I already forgot the second one. Oh, and when do we say we don't really need these epi links anymore because there's enough community transmission that being in St. Louis is the epi link that you need. So in terms of the first one, I think testing availability is, as Vicki said, being ramped up across the country. Our lab is working really hard on both additional options for send out that wouldn't have to go to the state, and also bringing online in-house testing so that we would be able to do that much easier. In terms of reagent, like whether that's a sort of finite limitation or whether that's going to be something that's ongoing, I don't really know the answer to that. I don't know if Neil knows the answer to that. Okay, so we'll just say pretty variable. We don't really know. And okay.
So this is Dr. Neil Anderson, and who has been doing an extraordinary job in the BGH lab, really trying to escalate our ability to have widespread testing. So thank you, Neil.
Yep, and his answer was that for those listening, that there have been a lot of FDA barriers and limitations in terms of getting these test kits up and running as well, and that's been sort of the limiting step, and it's hard to predict what the reagent offer will be. In terms of N95s, honestly, I would have to say no end in sight, not really clear what that's gonna look like. Even the plants that make these are often in these affected areas in China. They are not back up at full capacity. When they get back up to full capacity, there's obviously a huge need and a huge backlog that they'll be trying to fill. So I think we can anticipate being in a limitation situation for that for a long time. And then in terms of when we stop needing sort of an external epi link to really think about coronavirus, I think definitely we would all agree that when there is widespread community transmission and we're seeing lots of cases in the community, then we wouldn't be looking for that epi link anymore. It's very hard to put a number on what that means. It's a little bit of, I hope I'll know it when I see it. So that's something that we are monitoring very closely, and I think will be sort of a day-to-day, week-to-week sort of process to decide how that works.
Save card.
Oh, sorry. The question was for long-term care facilities and rehab facilities, what seem like appropriate measures to be putting in place right now to protect patients. And so I think that screening visitors at this point in the St. Louis area, that screening visitors for these epi links and for symptoms makes sense. I think always probably excluding anyone with symptoms makes sense. And particularly at this time, I mean, I think we are all, very concerned by what we saw in the long-term care facility in the state of Washington and the impact that infection getting into that facility really had with a very high mortality rate and rapid spread. So I think those are valid at this point. Personally, I think that in the St. Louis area right now, like excluding all visitors, probably isn't totally needed. But again, when we see widespread community transmission, whatever that is, then I would have a pretty low threshold for moving to that.
There's a lot of misinformation floating around the community currently, like both in the, I see a lot of people who are either freaking out and buying too much toilet paper, or not freaking out enough and like missing every thing is like people flowing without reporting. So these are great statistics and data for like medical people who can understand them. But if I start throwing like are not and like flattening curves for most of their eyes gloss over, so like what are some good strategies you found for like trying to combat that in the public without having to resort to like going
So the question was about misinformation in the community and best strategies to provide helpful information to thread the needle between panic and dismissal of the risk that's going on. So I think many of us in the ID division and the pediatric ID division as well have been being as active as we have time to be in responding to media requests to try and get some of this information out there. The messages that I usually try to deliver in those settings are, that people don't need to panic, but people do need to recognize that this is a brand new infection, that we have a whole population that has never had it before and there's no vaccine for, that while for children and for young, healthy people, this may not be a big deal, all of those children and young, healthy people interact with people that have health problems or are older people and need to think about what that risk means for them. I try and talk about the importance of our community mitigation strategies, though I don't always call them that, but just saying like we need to do things to minimize the risk that any one person can infect multiple people at a time, and that our goal is to be sure that if anyone is sick that they don't infect anyone or infect maybe one other person at most. And then I talk about the things again that are not exciting but that everyone should be doing, so hand sanitizing, hand washing, all of those things are really very important. And I tell people that it's important to go along with whatever public health tells us to do. So if public health tells us to stay home, we should stay home. If public health tells us not to have large gatherings or not to go to large gatherings, we should do that. If public health tells us not to travel to affected countries, we should not travel to those countries. So, we should use those strategies. So the question was about outpatient clinics and whether we should be encouraging patients with sort of routine visits to potentially delay those visits or cancel those visits at that time, and what kind of resources are available for remote visits and remote care provision. So I would say that I think it makes sense for offices to be aggressively screening for respiratory viral symptoms in patients and trying to keep patients that are sick from coming into your waiting room. I actually think this is probably a good idea every flu season. And having a process within your offices to be sure that if someone does come in with those symptoms, that you have masks, that you potentially have a way that you could separate to the extent possible sick people from less sick people. I think phone screening is sort of easily and available for everyone and is a good way that you can manage a lot of non-urgent questions and problems with patients. There are efforts going on across BJC and WashU to expand access to other virtual care technologies that people might be able to use. So there is work going on to try to make that more available. I don't have all of the details of exactly how and when, but know that that is something that people are aware of as a need and are trying to work on.
What the FPP is trying to do right now is to set up triggers in Epic using my chart that will go out ahead of time. They're also evaluating doing robocalls that, when they notify patients to remind them of their appointment, to have a clear script that says, if you're not feeling well, call your provider before coming in so they can reschedule you if that's a possibility, or if you determine if you really need to be seen. So they're working through that right now, both on the Epic side and on the sort of multiple messaging through texting and robocalls. So hopefully that will be coming soon.
Yeah, so the question was about if an outpatient practice does identify a person who has a potential epilink and symptoms, what are the next best steps to go down? At this point, actually calling the health department is a good idea, and they do have a hotline that they recently established. And so calling them and reviewing the case and whether they think they meet criteria for testing and whether they would run testing is still a good process. BJC and WashU are working on potentials for using these commercial labs in a way such that if you felt like there was an epilink and the patient was at risk, that you could arrange for getting that patient tested and get that test sent off without having to go through this health department process. But that is still kind of a work in progress. BJC is also looking at potential sort of testing sites where patients that are at home and need to be tested could be sent to go to a place to get their sample collected and get testing done. And so that is also something that's being looked at, what sort of sites are available for that, and actually working with Mercy and Luke's and SSM to try and have sort of coordinated geographic localization so that we could each like open up some testing centers that patients could be sent to try and get the test acquired. But once we have some of the lab sending process, I do think that these are patients that can, with appropriate sort of processes in place, could come into your facility, to your office to get tested, as long as like you knew they were coming and they could come right back and get the swab collected and a quick assessment, and then sent right back out without a lot of risk to others.
Justin?
So the question was about screening, not just for risk to the individual right in front of you, but risk to their contacts. And I'm really glad you asked that question because for secondary contacts, there is not a risk. So we don't worry about like so for example, if your child was infected and you went to a dance, the other people that's just an example. The other people at that dance are not considered exposed as long as that family member was asymptomatic. So the most important question is to ascertain the symptom status of the person in front of you and their personal risk. The risk of them being around someone with a potential exposure or secondary risk is really not a concern.
And just to doubly affirm, the person who went to the dance was asymptomatic.
Yes.
And there were no real exposures, although exposure perhaps to not the best judgment, and
right.
But
Still
not,
think it was a bad idea to go,
disease.
but everyone at the dance was not exposed, and there was no risk to the people at the dance. You,
I think what we'll do is stop now and. So the slides, we beam this out and they're online on the link, okay, for grand rounds, just like we do all the grand rounds. And what we'll do is keep collecting questions, and then we'll post those questions and answers on the same grand round.
And I will just mention there is a BJC intranet site that also has a frequently asked questions we update all the time, and WashU also has a coronavirus site, and you can also look there.
Hilary, thank you so much.
Thank you.